Hi, good morning, everyone, and welcome to the last grand rounds of this academic year. I'm very excited about today's Resident Research Symposium. Before we get started, a few quick reminders. To claim CME credit for viewing this presentation, please check your email after the presentation ends. If you have any questions or need more information, you can visit semelgrandrounds.com. For today, we'll be having two separate presentations, each with their own Q&A session. If you have a question for the speaker, you can use the Q&A session to submit at any time, either during the presentation or during the Q&A session. And now I'll turn it over to Dr. Martyr to give us a brief overview of today's Resident Research Symposium.
Thanks, Jonathan. One of the great things that UCLA has done over the years, a group of clinician physicians, clinician investigators, getting through a psychiatry residency alone, getting that clinical training can be an overwhelming experience. But I think we have to acknowledge that those who are able to do that and at the same time to complete quality research is particularly extraordinary. Both of our presenters today, Gil Hoftman and Juliet Edgcomb, are completing their adult residency this month. Both of them will be continuing on our faculty, and we congratulate them for their work. With that, I'm going to transition over to Carrie Bearden, who's going to introduce Dr. Hoftman. Carrie.
Okay. Hi, everyone. Good morning. I hope you can all hear me okay. And thank you all for joining today. I can't see you, but I see there are quite a lot of attendees, which is wonderful. And so I am delighted to introduce Dr. Gil Hoftman to you all today. I'm just going to say a few words about Gil. I first met Gil actually over a decade ago when he was a research assistant here in the Department of Psychology at UCLA in the lab of my colleague Ty Cannon. I could tell immediately at that time that Gil was going to be a rock star. And so he then went off east to do his MD Ph.D. at the University of Pittsburgh, and he stayed on to do his residency at UPMC, where he was the chief resident. And he also completed a research track fellowship in child and adolescent psychiatry, where he worked with David Lewis, who is one of the world's leading neuroscientists in schizophrenia. And there, Gil made some really important discoveries, which he'll be touching on in his talk today. And I wanted to mention that Gil's won some very important awards, not only for his scientific accomplishments, but also for essays he's written about humanism in medicine. And that's something that really shines through when you meet Gil, is not only his passion for science, but also for excellence in clinical care and really improving lives of our patients and everyone around us, which is a really important quality all the time, but it seems especially critical right now. And so I had kept in communication with Gil during his time in Pittsburgh and was just thrilled when he decided to come back to Cali and complete his psychiatry residency here at UCLA, which he'll be finishing very soon, as you heard, and then going on to do a postdoc in our neurogenetics training program. So I know Gil is going to go on to do wonderful, great things, in addition to all the great things he's already done. So all I can say is Gil has proved me right about his rock star qualities. And without further ado, thank you, Gil, for speaking to us today.
Thanks so much, Carrie. That is such a warm welcome, and I'm really proud to be here. And thank you all for the opportunity to share my research today. I'm going to share my PowerPoint screen, and I hope you guys can all see that clearly. So, you know, it's before I begin, given the times that we're in right now, sometimes it's hard to kind of pivot and talk about research and you know, these things that we are so fortunate and blessed to be able to do. So I just wanted to let everyone who's on here just observe a moment of silence and reflection for our grieving national community. Thank you very much. So today I'm going to talk to you a little bit about some of my work in trying to understand a piece of the underlying neural substrate in schizophrenia, and particularly in cognitive dysfunction in schizophrenia, with the idea that by identifying the alterations in this neural substrate during development, we may also be able to identify periods of vulnerability to schizophrenia. So before we get into the research itself, you know, why is it that I'm interested in this topic? Well, I have extended family members with schizophrenia and bipolar 1 diagnoses. So ever since I was young, I was aware that these conditions exist. And I saw, though peripherally, I saw how it impacted my family members' lives. From an intellectual standpoint, in 4th grade, I remember touching my first fixed human brain when a teacher brought it in for science. And this is a powerful moment that remains with me today. And it just kind of shows you also the powerful influence that people can have when you're young and when you have opportunity and are exposed to very different things in your environment. In high school, I also had the great opportunity after 9th grade to attend the National Youth Leadership Forum on medicine at UCLA. And this kind of propelled my interest in medicine. And in college at UCLA, I discovered an interest and a love for neuroscience research. I also worked with the homeless population in West Hollywood, and that's where I first met people directly with chronic untreated schizophrenia. And then I went to the University of Pittsburgh and Carnegie Mellon University, as you heard, to do my MD Ph.D. and cultivated interest in clinical psychiatry and developmental and molecular neuroscience. And now in residency and fellowship, I've had both at Pitt and CMU and here at UCLA, some key formative experiences, including most recently here in the UCLA Psychosis Clinic with Dr. Martyr and numerous amazing colleagues that have really solidified and revealed to me the urgent need for this research. And the bottom line for me is that too many patients suffer from symptoms which impede their daily life and their long-term goals. And we really are limited in terms of personalized treatment options. So my long-term goal is to use research and trying to understand the brain as one piece of developing more personalized treatment options for people who are suffering daily. So the learning objectives that I'd like to get across here is at the end of the presentation, I'd like you to be able to understand a tiny piece of the hypothesized underlying neurobiology of cognitive dysfunction in schizophrenia by being able to identify patterns of cortical, glutamate, and GABA gradients in postmortem human brain, by knowing how these patterns are altered in schizophrenia, and by naming 2 strengths of postmortem human brain studies. So, as we currently understand, the schizophrenias are varied syndromes, typically modeled by 3 symptom domains. And on the right of the slide, you'll see these domains overlap more or less, but they include many different symptom types. So positive or psychotic are typically the most visible, and they include delusions, hallucinations, and thought disorder. Negative symptoms include affective dysregulation, anhedonia or loss of interest, avolition or loss of motivation. And cognitive symptoms include disrupted sensory, motor, and thought processing. Now, we are able, with some success, to treat positive symptoms and some negative symptoms. And we are aware of cognitive symptoms, but we are really limited in terms of how we can treat those cognitive symptoms. Now, we also are acutely aware that the schizophrenias can be devastating to the individual, family, and community. People experience a high burden of daily disability, including physical, emotional, and cognitive challenges that impact their relationships, finances, education, and self-care. And in no small way, the stigma often compounds this suffering. So altogether and tragically, mortality is increased due to higher rates of suicide and earlier age at death on average by 2 decades. So as I mentioned, while psychotic symptoms often bring people to clinical attention, cognitive dysfunction is a core feature of schizophrenia since it's present and progressive prior to psychosis onset, and it's persistent regardless of the psychotic symptoms. We also know it's the best predictor of functional outcome from seminal work done here at UCLA by Michael Green, Keith Nectarline, and colleagues. And yet it remains undertreated and only partly understood. So in order to reduce the complexity of cognition, we study a more tractable target, which is called visuospatial working memory, or VS working memory, because it's a prototypical cognitive impairment in schizophrenia, and it's defined as the ability to transiently maintain and manipulate visual and spatial information in order to guide thought and behavior. So again, as I mentioned, I'm interested in the underlying neural substrate of visuospatial working memory dysfunction in schizophrenia. And what might that underlying neural substrate include? Well, we know from human and animal studies, non-human animal studies, that many cortical and subcortical regions are involved. And since there are many of these regions, why did we choose to study the regions highlighted in this figure? Well, we chose to study this because the information from visuospatial working memory is transferred from multiple cortical regions, including the primary visual cortex, the association visual cortex, or V2, the posterior parietal cortex, or PPC, and the dorsolateral prefrontal cortex, or DLPFC. Now, the PPC and DLPFC show altered activity during these kinds of tasks in subjects with schizophrenia. These regions also cover the spatial extent of the cortical mantle from back to front, and they also represent a hierarchy of visual and spatial information processing in the human brain that form this dorsal stream. Now, the brain, while it looks like a blob of tissue to the naked eye, when you look at it microscopically, it's organized in a very highly kind of structured way that include layers, that include many different types of cells. And this is what you see here in this wonderful drawing by Santiago Ramon y Cajal back in the early 1900s, when he was looking under a microscope at this tissue, and he drew these. Multiple layers of diverse cell types. They are typically 6-layered, and you could see the different layers here highlighted in the different boxes of colors, including the white matter, which is where the cables from these neural cell bodies go and transport information to different parts of the brain. And we focus here on layer 3. And why study layer 3? Well, the answer here has to do with the connectivity of these cells. So layer 3 cells, as you can see here, they transfer information carried by visuospatial working memory through their connections, both locally, both within an area, and then through the white matter into other cortical brain areas. Now, there are 2 major classes that can then further be subdivided, but there are pyramidal neurons, which is this little blue one, and you'll see the actual cell in a minute. And they use glutamate to signal their information. And these pyramidal neurons are modulated by a whole host of local neurons that use GABA. And so remember glutamate and GABA, because those are the markers that we're going to study. Now, this is what they actually look like when you stain them for a particular substance. They literally look like pyramids. These are the glutamate cells. And then this ovoid cell is a GABA cell. And what's interesting is that in schizophrenia, we know that there are alterations in both these glutamate and GABA cells, both structural and molecular, and that these alterations are more pronounced in the front, the DLPFC, than they are in the back, the V1. But there are changes in V1. And we do see molecular changes in mRNAs, or messenger RNAs, which are transcripts. And so this is what we chose to focus on based on a number of different studies. But prior to this study that I'm going to share with you, there hadn't been a systematic layer-specific multi-cortical region approach within the same human subjects in schizophrenia. So here what we asked is, do transcripts regulating key elements of glutamate and GABA neurotransmission normally exhibit regional differences in expression in layer 3? And second, how do any disease effects on expression impact the normal regional patterns of glutamate and GABA transcripts in the visuospatial working memory network? And the way we went about this is that we quantified functionally analogous markers of glutamate and GABA neurotransmission. And this included synthesis, transport, receptor subunits, and reuptake. And I'll give you a visual just so you can see, so they're not just a bunch of letters that are kind of disconnected from where they function. So in this glutamatergic synapse, you have glutamine that's converted to glutamate by a synthesizing enzyme that's packaged into vesicles by a transport, basically, marker. Then they're basically go into the synapse, they're released into the synapse where they act on postsynaptic receptors, and then they're taken back up by the glutamate transporter on astrocytes. We did the same thing for the GABA synapse, where we look at glutamate converted to GABA, packaged by a transporter into presynaptic vesicles, released into the synapse, and taken back up by another transporter. And we looked at the individual markers, and we also created a composite measure so that we could better understand what these markers might be doing together within the synapse. And the other methods that we used for this are laser microdissection microscopy and real-time quantitative PCR. The laser microdissection was used to cut out the layer of interest, as you can see here in the tissue. Panel A is the full tissue, panel B is with layer 3 cut out. And the quantitative PCR was used to actually get quantitative values of transcript expression levels. And just to give you a sense of the human subject demographics, we basically had 20 pairs of postmortem human brain tissue from schizophrenia and comparison subjects, matched for gender, age, and tissue quality measures. And the important thing here is that when we look between the groups, they were all not significantly different, and the measures of tissue quality were very high. Also, the age was around middle-aged adult, late 40s. So what did we find? So first thing that we found, and I want to take you through this figure because this is how the rest of the figures are going to be set up. So on the y-axis, you have the glutamate composite measure value. On the x-axis, you have the brain regions that we studied, with the back V1 toward the left and the front DLPFC toward the right. And in control subjects, what was striking is that we saw this gradient where the lowest expression was in V1 and V2, and the highest expression of the glutamate composite measure was in the front, the DLPFC. When we looked at these same measures in schizophrenia subjects, we saw that this glutamate gradient was blunted. So in V1 and V2, there was higher expression in glutamate in schizophrenia relative to control, and in DLPFC, it was lower. For GABA, we also saw an interesting gradient, but it was opposite to glutamate, where V1 had the highest levels, PFC had the lowest levels. And basically in schizophrenia, there was an alteration, but it was a different pattern of alteration, where the gradient was more enhanced for GABA. And so GABA levels in V1 and V2 in schizophrenia were higher than comparison subjects, and in PFC, lower. We also examined potential confounding factors, which is very important to do in these kinds of studies. The potential confounding factors that we looked on transcript expression levels within subjects with schizophrenia included cause of death by suicide or non-suicide, and whether a subject was on many different medications, including antipsychotics, antidepressants, benzos, anticonvulsants, or nicotine at the time of death. And importantly, statistically, there were no significant effects of any of these factors on any of the transcript studies studied here in any of the 4 regions studied. So just to give you a little discussion and implication, so in healthy adult layer 3, it's possible that this low glutamate high GABA transcript signature in V1 might underlie at least a molecular signature or the need for rapid detection and faithful tracking of stimuli during early sensory processing. And the opposite high glutamate low GABA transcript signature in the DLPFC might underlie the need for sustained recurrent excitation that's important for VS working memory information integration. Interestingly, the glutamate and GABA or excitation inhibition balance set point in layer 3 appears lower in the DLPFC and higher in the V1 in schizophrenia, but the ratios themselves remain stable. And so maybe lower glutamate and GABA neurotransmission in the DLPFC might be related to impaired increase in coordinated activity of layer 3 microcircuits to process and integrate visuospatial working memory information. So these are some speculations that need to be tested further, and I'll talk about some future directions a little later. But one thing that I'm always interested in is when we see these molecular changes in postmortem tissue, first of all, there are a number of questions that we need to ask, whether they're causal, whether they're consequence of the pathophysiology, whether they're compensating for something, whether they're just a comorbidity or a confound. Those are very important questions. But I'm also interested in, well, what's happening during development? Because we know schizophrenia is not a cross-sectional illness. It's very dynamic, and it occurs in the context of development. And I'll show you here that we think schizophrenia is a disorder of cognitive neurodevelopment because there is evidence that there are a number of things happening well before the onset of psychosis, which you see occurs here in late adolescence, early adulthood. There are impairments in cognition that begin during childhood, often years before clinical onset, and continue to worsen or split apart during adolescence and puberty. There are many structural variants associated with schizophrenia that implicate neurodevelopmental genes that are involved in neuroproliferation, migration, synapse formation. And these are some wonderful recent studies also done by Mike Yandel here at UCLA. There's also an excess of adverse events that occur during the pre and perinatal periods of development. So all of these point to the idea that schizophrenia is a disorder of neurodevelopment, and that there are a lot of factors that increase risk or maybe can mitigate risk prior to psychosis onset. The other important part of this is that visuospatial working memory function has a parallel and long protracted development associated with an increased recruitment in PPC and PFC during adolescence, and that results in better performance. And then there's increased activation of distant brain regions known to be related in timing and learning processes in adults compared with teens and children that suggests that this long distance functional integration of brain circuitry supports mature visuospatial working memory function. And the important thing here also, as you'll see, is that there are similar findings in non-human primates. So this may be something that's conserved in primates. And so one big question for me is, when during postnatal development are these adult-like glutamate and GABA transcript patterns established? And the reason I say in monkey cortex is, unfortunately, there's a huge dearth, so a lacking of postmortem juvenile human brains, so in the childhood period, which is good because that means that we don't have that many children dying. And it makes it tough to study what normal circuitry looks like and put this post-mortem adult findings into developmental context. So we used rhesus macaque monkeys, a subject cohort of 30, age range of 1 week after birth, neonatal, to 12 years old, which is mid-adult, split into 4 age groups. And what we did here is that we used the same methods. We looked in the same 4 regions in layer 3, quantified the same glutamate and GABA markers using laser microdissection and qPCR, looked at the exact same individual markers of glutamate and GABA synthesis, and created the composite measures. And here's one finding that we have. So again, each of these panels that you see on the screen is the same kind of graph where you have the composite measure on the y-axis and the regions on the x. And now each panel is an age group. These are all layer 3, and this first set of 4 panels is for glutamate. And basically what you see is the first time that you have this adult pattern that's significant is here in the prepubertal period. So not right after birth, but before puberty. For GABA, again, we see this opposite pattern starting to form, and the first time it's significant is during the peripubertal, or during what we would consider puberty or adolescence period, and it stays significant to adulthood. So if we highlight these 2 first significant findings, you see there's kind of a temporal offset where glutamate seems to achieve this pattern earlier, before puberty, and GABA kind of after puberty onset. So some discussion and clinical implications for this. Well, maybe earlier developmental risk for disrupting this neural circuitry would impinge on glutamate in the DLPFC. whereas later developmental risk might impinge on GABA in V1. And some speculative interpretations that no doubt will need to be tested for schizophrenia is perhaps the DLPFC glutamate blunted developmental increase results in a compensatory decrease in GABA, or a molecular version of hypofrontality. Whereas in V1, the GABA excessive developmental increase may lead to compensatory increase in glutamate, or maybe a hyperoccipitality at the molecular level. And so if these end up being true, well, then that has implications for interventions. And this may mean that, putting something that increases GABA or changes glutamate across the entire cortex might somewhat help, but then come with also adverse events and hurt in other parts of the brain. So maybe we might use region-specific TMS or transcranial magnetic stimulation for cognitive and negative symptoms. Maybe CBT and neural training to alter cognitive function early in the disease process can do this organically. And maybe if we can come up with medications that target very specific circuits, we'll have better luck trying to treat cognitive and negative symptoms. So shifting over to some strengths that I wanted you to learn about. First of all, using postmortem tissue has a lot of limitations, and I'm happy to talk about that as well. But you have direct access to diseased tissue. You also have the highest level of molecular cellular circuit resolution currently available. And then you can also use non-human primate neural circuit model to provide a developmental context for these molecular alterations in postmortem human disease. Some limitations, well, just look at the difference between the size of a mouse, the size of a rhesus monkey, and the size of a human brain. And if you look at the specific regions, the frontal cortex, much more expanded in the human than in macaque. And interestingly, the visual cortex actually takes up a lot less real estate compared to the rest of the cortex in human than it does in macaque. So we always have to ask ourselves, well, how good is this model for the questions that we're asking? And what are the limitations? Well, we can't understand the mechanisms underlying these gradients in non-invasive and in situations where we can't manipulate it. So future directions, I think layer and cell type specific whole genome sequencing studies in human and monkey cortex is critical for developing a more global understanding of gene expression and regulation in schizophrenia and during postnatal development. Here we were limited because of basically qPCR approach to pick just a few markers. I think we need to use higher resolution neuroimaging methods to develop non-invasive measures of cortical structure and function in vivo, so we can take a more dynamic approach during development and progress of the illness rather than cross-section. And there's a major gap in critical need for high quality brain tissue from childhood and adolescence. So in summary, basically in human postmortem layer 3, for glutamate, transcripts are lower in the back, V1, and higher in the front, DLPFC, while GABA transcripts are opposite. These patterns are altered in schizophrenia such that glutamate is blunted while GABA is enhanced. And postmortem human brain tissue provides advantages, including direct access to pathological tissue and studying typical tissue at the circuit cell molecular level of resolution that I think is going to be important for understanding the biological substrates of schizophrenia. So with that, I'd like to say thank you very much to all the people who have been so helpful, including David Lewis at Pittsburgh, to the UCLA residency program that's been so welcoming. It's a tough transition in general, and especially with all that's going on. Thank you so much. To all the mentors that have already made a huge impact, including Carrie, Nelson Freimer, Dan Geschwin, Mike Gandel, Jen Forsyth, Erica Nurmi, David Kranz. I could just name on, and Steve, you've been awesome. And of course, to the donor families who provide the brain tissue from a loved one during such a difficult time in their lives and make this research possible. With that, I'll stop for questions.
All right. Thanks so much, Dr. Hoftman. I think in the interest of time, we're going to go ahead and move to Dr. Edgcomb's presentation. So we'll do a combined Q&A at the end. So if somebody has questions, please just make sure to say whether it's for Dr. Hoftman or Dr. Edgcomb. So with that, I'll transition over to Dr. Brooks, who's going to be introducing Dr. Edgcomb this morning.
Hi, thank you, Jonathan. Hello, everyone. Thanks for coming. I'm glad to introduce Juliet Edgcomb and her talk. I've had the pleasure of knowing Juliet for a few years, both in clinical settings and in research settings here at UCLA. Dr. Edgcomb is a fourth-year resident and also one of our chief residents here in psychiatry. After completing her MD and her MD, Dr. Edgcomb also got a Ph.D. in social psychology at UC Riverside. And she was actually one of the youngest people to receive a Ph.D. in the UC system. As part of her doctoral work, she worked to develop longitudinal models of speech patterns in physician-patient dyads. More recently, in the course of her work at UCLA, her interest had developed into the application of computational models applied to electronic medical health records to understand psychiatric health services in the context of mental illness. Now, when I met Juliet, I work on the psychiatry consultation service in the Reagan Hospital, and Juliet was in the second year of residency on the service, and we were talking and asking Juliet what some of her research interests were. She mentioned that she enjoyed computational models and working with large data sets. And as luck would have it, I had actually recently worked to extract part of a large data set. And if you talk about great fortune as a faculty member and having lights go off, to hear Juliet say that was one of her interests was really a wonderful thing. And so I've enjoyed working with Juliet since that time. And in some of the work that she'll describe today, Juliet has since expanded that data set and our collaborations with others in terms of looking at how we can derive important understanding from electronic medical health records in terms of risk factors associated with serious mental illness and the delivery of psychiatric health services and the complication of serious medical illness in that context. I do want to say that Dr. Edgcomb has received a number of awards during her residency here at UCLA, including the American Psychiatric Fellowship, Child and Adolescent Psychiatric Fellowship, the Laughlin Fellowship, the Webb Fellowship, the DeLynn Fisher Clinical Research Award, the Psychiatric Clinical Fellowship Association Hatos Prize, and the National Institutes of Mental Health Outstanding Resident Award. Next year, I'm glad to say that Dr. Edgcomb will continue in clinical and postdoctoral training and her research work here at UCLA in an NIMH T32 Research Track Fellowship as part of the Child and Adolescent Psychiatry Division. And we're all very happy for that. And so now I will turn it over to Dr. Edgcomb so she can begin her presentation.
Thank you, Dr. Brooks. All right, I'm gonna get my screen loaded here. Okay. Hi, everyone. The title of this talk is Suicide Attempts and Self-Harm After Medical Hospitalization Towards Solving the Complex Classification Problem. I'm Juliet Edgcomb, and I'm excited to share some of our new research in this field. My disclosures are that I'm employed by the University of California. I have support from the APA Foundation Child and Adolescent Psychiatry Fellowship, a research grant from the American Foundation for Suicide Prevention. I'm going to be a trainee, as Dr. Brooks mentioned, in the T32 Fellowship and Child and Adolescent Fellowship next year. And the research I'll be presenting would not have been possible without the dedicated support of the UCLA Clinical and Translational Science Institute, which is funded by the NIH and CATS National Center for Advancing Translational Science. Suicide-related behaviors among people with medical illness are of increasing societal concern. And while we know that suicide is a public health crisis with increasing rates for the last 3 decades, the public health events in 2020 have brought to light the importance of predicting and preventing adverse mental health outcomes, including suicide, after medical illness, particularly among people with pre-existing serious mental illnesses who become additionally burdened by medical disease. But the majority of research in post-hospitalization suicide-related behavior has focused on psychiatric as opposed to medical hospitalizations. However, after medical hospitalization, people experience a unique and complex array of vulnerabilities that can destabilize mental health and engender emergence of suicidality. Medical hospitalization can result in mental distress, pain, functional impairment, financial stressors, and exacerbation of chronic mental illness. This is the results of a prior population-based study by Quinn et al. Of about 500,000 people in Denmark. And they found that the proximity to and frequency of medical hospital admissions predict risk of serious suicide attempt and suicide completion. In fact, half of people who suicide within 3 days of hospital discharge were hospitalized for non-psychiatric reasons. Thus, the recently medically hospitalized are both a vulnerable population and, as a function of their recent contact with healthcare providers, a very important group to target for potential interventions to reduce suicide risk. But the long list of potential predictors of suicide in multi-morbid populations is daunting to clinicians and researchers alike, and generally not well suited to traditional statistical approaches that are limited to a small number of predictive variables. Electronic health records and their associated data mining methods are emerging as a major area of study for clinical and translational research in psychiatry, and use of EHR data for suicide prediction has gained traction within psychiatry quite substantially over the last few years. For example, and now in the scheme of things, relatively older study, Barak Koren's really seminal work in AJP, using longitudinal EHR data to develop and validate risk prediction models for suicide attempts and death by suicide in the large healthcare system. So triaging risk of suicide helps to allocate resources and direct referrals to psychiatric care. And the goal with data mining techniques in EHR data is ultimately to take a large population potentially at risk of a costly and adverse outcome, such as suicide, and identify clusters or behavioral phenotypes of people who experience an elevated risk for that outcome. If this is successful, we can then begin to direct high-risk groups toward tailored interventions, and EHR data are one means to do this. So today, I'm going to briefly present the results of 2 studies we conducted using EHR data and newly applying EHR predictive analytics to answer questions about risk of suicide attempt after medical hospitalization in people with existing serious mental illness, with the caveat that these are studies that are written up and actually in review, with hopefully being published in the near future. So the goal of this first study was to classify risk of hospital readmission for serious suicide-related behavior in the year following an all-cause general medical hospitalization. And to do this, we leveraged EHR data from the UCLA health system and applied a supervised machine learning approach to identify specific risk factors and risk factor combinations predicting readmission for suicide attempt after general medical hospitalization. And the algorithm was jointly informed by both automated feature selection and psychiatrist expertise. So although all cases of suicidal behavior are important, in this work we focus on general hospital admissions for suicide attempt and self-harm to capture behavior requiring inpatient medical care for physical sequelae. So it's important to note that we used a relatively restricted definition focusing on medically serious suicide attempts involving medical admissions. Moreover, we focused on people with serious mental illnesses, which we defined as mood disorders and chronic psychosis, as these individuals experience both a high propensity for medical illness and an elevated risk of serious suicide attempts and self-harm, and thus are a population that's vulnerable to adverse outcomes after medical hospitalization. And by exploring the critical intersection of acute medical illness, serious mental illness, and serious suicide-related behavior, we aim to identify hospitalizations that are potential key prevention and intervention points. So to do this, we used EHR data from medical inpatients in the UCLA health system across 2 large quaternary care hospitals, Reagan and Santa Monica, totaling 700 beds. And this is a general schematic of our study design, but essentially data from 1 year prior to and including the first, or what we'll call index general hospitalization, were used to predict the likelihood of subsequent hospitalization associated with suicide attempt or self-harm in the year after a medical discharge. And we had data available from 2006 through 2017. We extracted information on diagnoses, medications, outpatient and inpatient visits, admission, discharge, transfer information, vital signs, pain score, chief complaint, demographics, zip code, and financial charges. And in case it sounds like a lot, there were a lot. There was in total over 350 potential predictors. Machine learning is a field of computer science that uses statistical techniques to give computer systems the ability to learn, in other words, progressively improve their performance from data without being explicitly programmed. And we applied a supervised machine learning approach to this EHR data in order to identify high-risk clusters. This schematic on the slide is to show you that one of the most readily interpretable machine learning models is a decision tree. The tree sequentially partitions data based on an outcome of interest. For example, for the outcome play versus don't play outside, the most important variable is the weather, sunny versus overcast versus rainy. And as you can see on the left, if it's rainy, the next most important variable is the wind condition. So we took our large set of predictors and used these to inform a machine learning classifier. On the left, we have a list of potential predictors, some properties of the patient, some properties of the encounter, and we put these into a classifier in order to generate a prediction for each individual patient. Our data sample contained information from about 200,000 encounters of individuals with serious mental illness, and of these 15,644 encounters met our inclusion criteria, and 218 were associated with a readmission for suicide attempt. In other words, there was a base rate among people who are generally medically hospitalized of being readmitted for a suicide attempt of about 1.5%. Most of our patients were female, most were white, and albeit with some diversity of population, not very representative of the greater Los Angeles area, and this is an important limitation to external validity. In total, we had about 3,000 patients across 15,000 hospitalizations. Almost half of the population had a psychotic disorder, a third a depressive disorder, and the remainder bipolar disorder. And of note, most people were seriously medically ill with a Van Wallraven score, which is a proxy measure of in-hospital mortality of greater than 10, where the absolute number represents approximately the percent risk of death in the hospital. This is a diagram depicting with the y-axis the number of counts of patients and the x-axis common medical conditions, showing that the medical conditions of the patients ranged from hypertension to fluid and electrolyte disorders, chronic ischemic heart disease, renal failure. So quite a medically ill population. And here's the decision tree. And we'll break this up so it's easier to interpret, and I'll focus on some key findings. But this is to demonstrate that it's a highly visual representation of clusters of risk within the data. Before we go through it in more detail, just a note about our model fit. The overall model fit for the decision tree I'm presenting was in the 80s in terms of sensitivity and specificity. And most machine learning models of suicide detection have area under the curve and similar statistics around 0.6 to 0.8. So our model performed quite well from a fit standpoint. So a couple of key findings. The highest risk subgroup were individuals with a history of suicide attempt or self-injury, and the gray box represents the entire population with 218 positives in the 15,000 encounters. And the red box is the first branch of the tree. This represents the most important risk factor. And in this case, as we well know from the suicide literature, it was history of suicide attempt or self-injury. And in this population, about 69 out of 389 hospitalizations among people who had a history of suicide attempt when they were generally medically hospitalized were followed by an attempt. In other words, people who have a history of suicide attempt or self-injury and serious mental illness who are generally medically hospitalized, not necessarily for suicide attempt, have 12 times the risk of readmission for attempt compared with medically hospitalized people with serious mental illness who have no history of attempt. Another important predictor was medical comorbidity, which we defined by Elix-Hauser category diagnoses. And just to show you an example of how predictors interact, we found that amongst people with serious mental illness and medical hospitalization who had no history of suicide attempt or self-injury and who generally were medically well, in other words, they did not have medical comorbidity or less than 2 Elix-Hauser category diagnoses, and who were young, were quite high risk. Their risk was almost 9% compared to the baseline population of 1.5%. So this tree approach allows us to identify interactions between predictors. Also, there were quite a substantial number of patients who did not represent for suicide attempt, and the model enabled us to identify low-risk populations of people who for whom there were no hospitalizations for suicide attempt. So some key points from this first study: a small population of people with serious mental illness are at high risk of attempt after hospitalization. Machine learning helps us narrow hundreds of potential variables into something like 12 that get into our tree. And then most predictors are interdependent and nonlinear. So we found that things like age and medical comorbidity, alcohol use disorder and borderline personality disorder, bipolar disorder and medical comorbidity, all of these predictors interacted with each other, and you could see these interdependencies within the trees. Overall, in terms of predictors, we found that people with a history of suicide attempt and self-injury were most likely to return, which is interesting because medically ill populations, even with serious mental illness, are infrequently screened for history of suicide attempt. We also found that people who are young and medically well are likely to come back, and this might suggest that new medical illness among people who have serious mental illness and who are young may be particularly destabilizing, whereas very ill people with very high medical comorbidity scores were less likely to come in. And there's a number of reasons why that may be the case, but in general points to the idea that we need to look at end stage of medical illness in mentally ill individuals as an important time period. So this line of work kind of grew organically into another project specifically investigating predictors of suicide attempt after medical hospitalization of women. So where this idea came from is I presented the results of the first study at the American Medical Informatics Association, and there, in the context of giving a poster, I met a wonderful collaborator, and really that collaboration has grown together with Weill Cornell Medicine in order to try to apply some of our machine learning models to the New York City Clinical Data Research Network, which contains data from over 11 million patients. So this research question came about because there's well-established sex differences in suicide risk, and rates of suicide are disproportionately rising among women in the United States. Over 700,000 women attempt suicide each year, and we know that most women who die by suicide had recent contact with healthcare providers. They have similar risks in terms of medical hospitalization. However, the vast majority, and I didn't say all, research has focused on obstetric hospitalizations and not on non-obstetric medical hospitalizations of women and specific risk factors for women in that context. So we developed a machine learning algorithm that identified specific risk factors of suicide attempt and self-harm after general hospitalization using EHR data from 1,600 women at UCLA, and then to assess replicability, we applied the same algorithm to a larger sample of 140,000 women in the New York City Clinical Data Research Network. And what's interesting is that we not only intentionally excluded obstetric hospitalizations, but the majority of women in our study ended up being postmenopausal with an mean age of around 60 years. So this is our flowchart for study inclusion. To point out that for UCLA, we had a small haystack with a small needle of 109 readmissions for suicide attempt in 8,400 hospitalizations, and a bigger haystack with a bigger needle of 40,000 readmissions for attempt within 840,000 hospitalizations in the New York data. So when applied to the UCLA data set, our classification tree algorithm identified 73% of rehospitalizations for suicide attempt and self-harm with an AUC of 0.73. And when applied to the New York City data set, the model identified 67% of rehospitalizations with an AUC of 0.71, which again, if we think about the general standard in the field, is somewhere between 0.6 and 0.8. We're kind of in the middle of that. So these are the data set decision trees with UCLA on the left and New York City on the right. And I realize this is not readable, but I wanted to point out what was really interesting is that the same pattern of predictors appeared in both data sets. So, we were concerned in the UCLA data about potential for overfitting. We have a rare outcome. We only have 109 readmissions. But then when we applied the same classification algorithm in the New York City data set, where we have 40,000 readmissions for suicide attempt, within hundreds of thousands of admissions, we found similar patterns. So that was very exciting. And in fact, they were so similar that I can present to you a combined tree, which demonstrates common pathways to risk. So the right branch, you'll see that women with serious mental illness and low antecedent medical comorbidity, so who are generally medically well before they were hospitalized, and who were younger than 55 years old, were at increased risk. So similar pattern to the other analysis, the first study, in which we found that young people with serious mental illness who are newly medically hospitalized have a vulnerability to suicide attempt in the year following that medical hospitalization. And then on the left, we found, very interestingly, that women with some medical comorbidity and no history of suicide attempt or self-harm, the next most important predictor was history of pregnancy-related mental illness. And this was particularly interesting because our women were all postmenopausal. So this is decades later, after a potential pregnancy-related mental disorder, we're seeing that it may convey increased risk for suicide attempt after medical hospitalization. So some key points from this study: one, antecedent medical comorbidity is a key modulator. It actually appeared in both trees higher than history of prior suicide attempt, which was interesting and points to the idea that it's important to look at predictors of risk potentially separately for men and women, and then to validate in multiple data sets. We also found that classification trees performed well in two very different models of care, where we have UCLA, which is a very specific health system, versus a set of 10 health systems in New York City, and we were able to generate relatively predictive algorithms in both data sets. And then there's this interesting question of, why does history of pregnancy-related illness, mental illness, come up as a key risk factor for suicide attempt after non-obstetric medical hospitalization? And I'm interested in exploring this more because women who have a history of pregnancy-related mental illness may be particularly susceptible to stressors associated with acute medical illness and medical intervention, including loss of identity, threats to autonomy, health illness transitions. There could be a role for psychological trauma associated with hospitalization for childbirth that may retain vulnerability into subsequent hospitalizations. So a really interesting line of research questions kind of came out of this analysis. So taken together, there's significant promise in leveraging EHR data to better understand patterns of care utilization in people with psychiatric disorders, but there's also a number of important limitations. A big N becomes a small n when we consider case positives for a rare outcome, and this is a very well-described limitation in suicide research given the rarity of the outcome. Moreover, we're relying on ICD codes in structured EHR data, and I'd like to know how many medical hospitalists are correctly diagnosing and billing for suicide attempts specifically. Probably fewer than could be. And likely that 1.5% rate of readmission for medically serious suicide attempts significantly underestimates the number of actual attempters, which points toward developing better EHR cohort identification strategies for suicide. And then EHR data are inherently limited to the information routinely collected in the course of medical care. We only capture people during periods of illness. We frequently have missing data, and we're relying on clinicians to document and describe these populations. In the future, we plan to grow this line of work by expanding and updating the UCLA and CDRN data pools through 2020, in turn capturing COVID-related hospitalizations, as well as less acute forms of suicidality. EHR data can also be linked by patient zip code to the US Census data to extract environmental and contextual variables. And finally, although behavioral phenotyping of provider notes using natural language processing is increasingly promising, very little work has explored medically ill patients with psychiatric comorbidity and the complexities involved in tracking and intervening on acute psychiatric outcomes using natural language processing and other more advanced EHR mining techniques in these vulnerable populations. So I want to leave a few minutes for questions, but before I do that, I want to give a big thank you to our research team at UCLA, including my primary mentor, Dr. John Brooks, my statistical expert, Gerhard Helleman, my co-resident, Trevor, who helped with some of the analyses, and thank you to our wonderful collaborators at Weill Cornell Medicine, Jody Pathak and Rohit Thiruvalluru, and the tireless and timeless efforts of the UCLA CTSI, who have helped us extract and re-extract this data. So I'll pause now for any questions.
All right. Thank you so much, Dr. Edgcomb and Dr. Hoftman. So if anybody has questions, feel free to use the Q&A function. We have one question that's come in so far. This one's for Dr. Hoftman. This is, has anybody studied the relationship between the transcripts that you examined and in vivo magnetic resonance spectroscopy measurements of GABA and or glutamate?
Yeah, thank you for that question, Emily. There has been a number of glutamate and GABA MRS studies, and with higher resolution, they're starting to become less mixed. There are some evidence of decrease in certain regions in the frontal cortex of glutamate, but then there's other counter evidence of increasing glutamate. It depends on the region studied, and it depends on the level of resolution that people have. And then there's also some studies showing decreasing GABA. But in terms of actually looking at specific networks and really kind of honing in on specific regions, we don't have that yet.
Thank you. We have another question. This one's for Dr. Edgcomb. Did you have any way to identify completed suicide after medical admission?
So that's a great question. And I think it points to the using the data you have versus the perfect data. In order to tie death data to EHR data, we need to use identified patient data in order to link those two data sources. And so in this analysis, we did not look at deaths outside of the hospital. We were able to determine whether a patient who was admitted died during their admission, but that is a limitation to our data, but something we would like to explore in future work. What it would require doing is getting likely social security numbers or other identifiers and then linking to master death files. Really interesting question, and something that some of the folks out of MGH have been exploring more. So an area that we hope to get into in the future.
All right, thank you both. It's just about noon, so we're going to go ahead and wrap up this grand rounds. And I just wanted to say thank you for presenting your work. And I always find it just fascinating and so amazing to see all the work that's going on. And I'm happy to kind of give this venue for you all to share what you've done. So thank you so much. And thank you all for coming to grand rounds today.
Thank you.
Thanks.